Ever had that feeling? Like a sudden, really intense throbbing pain in a joint. Almost like, I don't know, tiny shards of glass decided to throw a massive, painful party.
Yeah, it's a pretty vivid description.
And you see that classic picture, right? Someone just grabbing their big toe in agony.
Absolutely.
Well, that's exactly what we're diving into today. We're talking about gout.
That's right. And we've basically boiled down all the key info from the revision notes, specifically thinking about the MSRA.
Think of this as your high-yield shortcut.
Yeah.
We want you to feel really comfortable with gout.
Yeah, we'll break it down bit by bit, focusing on what you really need to know.
Exactly. So our mission today, make gout crystal clear. We'll cover what it is, what kicks it off, who's more likely to get it, how it develops pathologically.
What else it might look like, so differentials.
Right, who gets it demographically, how it actually shows up clinically, how we diagnose it, management, prognosis.
And, yeah, the potential complications, too. A structured approach to nail this topic.
Perfect. Ready to start with the absolute basics. What is gout, fundamentally?
Okay, so, simply put, gout's a type of inflammatory arthritis. Its main feature is those recurrent, really severe attacks of joint pain.
And it's not just pain, is it?
No, exactly. You get redness, swelling, tenderness. The joint just feels, well, angry, very inflamed.
And what's making the joint so angry? What's the underlying culprit?
It's the buildup, the deposition of uric acid crystals. These form in the joints and also in the tissue surrounding them.
Like tiny sharp needles causing irritation.
Precisely. And it helps to think about gout in stages, to understand how it progresses.
Okay, walk us through those stages.
So first you have the gout flares. These are those acute sudden attacks we mentioned, often in the lower limbs.
What triggers them?
Common triggers include things like drinking alcohol, eating rich, fatty foods, or even just getting dehydrated. And the key features are that extreme pain, the redness, swelling. It can be quite disabling, actually.
Sounds awful. What happens after that flare settles down?
Then you enter what's called intercritical gout. This is the time between flares. You might feel completely fine, no symptoms at all.
A bit deceptive, then.
It can be, because the important thing to remember is, as the disease progresses, the symptom-free periods tend to get shorter and shorter.
Okay. And then there's a more long-term picture.
Yeah, that's chronic gouty arthritis, or sometimes called tophaceous gout. This is when you start developing TOFI.
TOFI.
These are basically lumps of those uric acid crystals that build up under the skin. Usually not painful themselves, at least not initially.
Ah, right. Those little nodules you can sometimes see or feel.
Exactly. And just briefly, there's a formal classification system updated in 2015. It's very comprehensive, looks at joints involved, how the episodes behave, the time course, presence of TOFI, blood urate levels, joint fluid findings, imaging.
Wow, okay.
You don't need to memorize every detail for the MSRA, but it just shows how doctors look at the whole picture to classify gout.
Got it. So that's the what's. Now let's dig into the why. What causes this uric acid to build up in the first place?
Well, fundamentally, it's about having too much uric acid in the body. When the levels get high enough, it starts to crystallize out.
And why would someone have too much?
It's usually one of two things, or maybe a combination. Either the body is producing too much uric acid, or perhaps more commonly, the kidneys aren't getting rid of it efficiently enough. Underexcretion.
Okay, production versus excretion. What influences that balance?
A few key things. Diet definitely plays a role. Genetics are important. Some people are just predisposed to handle uric acid less effectively. And other medical conditions can contribute too.
Diet comes up a lot with gout. But you also mentioned medications can be a trigger. Tell us about drug-induced gout.
Yes, this is really crucial for clinical practice. Certain medications can cause chronic hyperuricemia. That's the persistently high uric acid level, which then triggers gout.
Which drugs should we be aware of?
Well, diuretics are a big one, particularly thiazides and furosemide. Also, cyclosporin, which is an immunosuppressant. Alcohol, which we should think of as a drug in this context. Also, some cytotoxic agents used in cancer treatment, pyrazinamide for TB, and even low-dose aspirin.
That's quite a list of common drugs. Anything that can help if someone needs one of these meds.
Interestingly, yeah. The notes mention that allopurinol, that main drug we use to lower uric acid anyway, might actually help counteract the gout risk from diuretics and low-dose aspirin in some people.
Huh, that's a useful clinical pearl. Okay, so causes covered. Now, risk factors. Who is most likely to develop gout? What are the key things for the MSRA?
Okay, let's list them out. A big one is diet specifically. A diet high in purines. Purines break down into uric acid.
So that's the red meat, the seafood.
Exactly. Red meat, certain seafood, and again, alcohol, especially beer. Obesity is another major risk factor.
Okay.
Then there's hypertension, chronic kidney disease.
Yeah.
These increase your risk. Medications, as we just said, particularly diuretics.
Right.
Family history is important. If it runs in your family, your risk is higher. And gender, it's much more common in men.
The women can get it too.
Oh, absolutely, especially after menopause. And other things often associated include coronary heart disease, diabetes, and high triglycerides.
Lots to remember there.
There's actually a handy mnemonic that might help. Think male dog,
Real dog.
male gender, alcohol, low kidney function, CKD, eating purines, meat, seafood, diuretics, obesity, and genetics, family history.
Male dog. I like that. That definitely helps pull this together. Great. Now let's get into the nitty-gritty, the pathophysiology. How does it actually happen step by step inside the body?
It's actually quite logical when you break it down. It starts with those high levels of uric acid in the blood, hyperuricemia.
Okay.
When the concentration gets too high, it exceeds the solubility point, and the uric acid starts to form these tiny, sharp, needle-like crystals, monosodium urate crystals.
And they form in the joints.
Yeah, they tend to deposit in joints, often in cooler areas like the big toe, but also in tendons and surrounding tissues. And it's the physical presence of these sharp crystals that triggers the body's inflammatory response.
So the inflammation is the attack.
Essentially, yes. The immune system sees these crystals as foreign invaders, sends in inflammatory cells to try and clear them out, and that whole process causes the intense pain, the swelling, the redness, the gout flare.
Right. The body's defense mechanism causing the symptoms. Makes sense. Okay, so we know what gout is, how it happens, but if someone comes in with a hot, swollen, painful joint, it's not always gout, right? What else needs to be on our radar? The differential diagnosis.
Absolutely crucial, especially for acute attacks. The number one thing you must rule out is septic arthritis.
Joint infection.
Exactly. It's a medical emergency, needs urgent treatment. So that's top of the list. You also need to think about other types of crystal arthritis, like pseudogout.
Caused by different crystals.
Yeah, calcium pyrophosphate crystals. Looks similar sometimes.
Okay. And what about for the chronic picture with the TOFI?
If you see those chronic changes and TOFI, you might also consider things like rheumatoid arthritis, although the nodules are different. Maybe severe osteoarthritis with bony lumps. And less commonly, conditions like xanthomatosis, which involves fatty deposits.
Good to keep those alternatives in mind. Now let's zoom out a bit. Epidemiology. Who actually gets gout? What are the UK numbers like?
So in the UK, it affects roughly 2.5% of the population, which is actually quite a lot of people.
Yeah, that sounds pretty common.
It is. And as we said, it's much more common in men, and prevalence definitely increases with age. It's pretty rare in people under 20.
Any global trends?
Yeah, it's considered the most common inflammatory arthritis worldwide. That pattern of male predominance and increasing prevalence with age holds true globally.
Interesting.
A UK study back in 2012 put the prevalence at 2.49%, incidence around 1.77 per 1,000 person years, and that male-to-female ratio was about 4.3 to 1.
Quite a skewed ratio.
It is. And interestingly, prevalence seems higher in certain regions like Oceania, North America, and among some indigenous groups. Suggests a role for, genetics or maybe specific environmental factors in those populations.
Fascinating. Okay, let's get back to the patient. Clinical features. Paint us a picture of a typical gout presentation in the UK. What should make us immediately think gout?
The absolute classic is that sudden, severe onset of pain in a single joint, usually accompanied by marked redness, swelling, and the joint feels warm or hot to touch.
And often the big toe.
Very often, the first joint involved is the metatarsophalangeal joint of the big toe. That's podagra. Definitely know that term.
Got it.
But it's not just the big toe. It can hit the ankle, the midfoot, the knee, wrist, fingers, elbow. And sometimes the person might even feel generally unwell, maybe have a bit of a fever during the flare.
So podagra is common, but it can be other joints too. What else characterizes the attack itself?
The speed of onset is really characteristic. The pain often ramps up very quickly, usually peaking within about 12 hours or so. The joint is incredibly tender. Even the weight of a bedsheet can be unbearable, and it looks visibly inflamed, red, and swollen.
If it keeps happening.
That's the worry. Untreated recurrent attacks can lead to chronic joint damage over time.
Okay. And those TOFI you mentioned earlier, what do they actually look and feel like on examination?
They're usually firm lumps you can feel under the skin. Sometimes they can look a bit yellowish or chalky white through the skin.
Where do they typically show up?
Common spots are around the elbows, over the finger joints, on the feet, maybe even along the Achilles tendon. Finding TOFI really points towards chronic, often undertreated gout, and they themselves can cause joint destruction and ongoing pain.
So bottom line, sudden, severe, red, hot, swollen joint, especially the big toe. Think gout strongly.
Exactly. Acute monoarthritis should always raise suspicion, even oligoarthritis of few joints. And don't forget chronic gouty arthritis, which is more about persistent, nagging joint pain, even between the big flares.
Right. The image we have clearly shows that classic podagra red, swollen big toe.
Okay, so suspicion is high. How do we actually confirm the diagnosis? What investigations are key?
Well, it always starts with good clinical assessment. Taking a detailed history, asking about previous attacks, triggers, family history, and a thorough physical exam, looking carefully at the affected joints.
And then labs.
The absolute gold standard is synovial fluid analysis, tapping the joint.
Yeah, arthrocentesis. We draw off some fluid from the inflamed joint and look at it under a special microscope, a polarized light microscope.
And what are we looking for?
We're looking for those monosodium urate crystals. They have a very specific appearance, needle-shaped, and they show negative birefringence under polarized light.
Needle-shaped negative birefringence. Key phrase.
Absolutely key. If you see those, that confirms the diagnosis of gout. We'll also usually check blood tests for inflammation markers, like ESR and CRP, which will likely be raised during a flare. The white cell count might be up too, especially neutrophils.
What about the uric acid level in the blood? Isn't that important?
It is, but with a really important caveat. Serum urate levels are best checked after a flare has completely settled, ideally 2 weeks or more later.
Why is that?
Because, paradoxically, the serum urate level can actually be normal or even low during an acute gout attack. So a normal level during a flare doesn't rule gout out.
That's a crucial point for exams and practice. Okay, what about imaging? Does that help?
It can, especially in more chronic cases or if the diagnosis is uncertain. X-rays might eventually show characteristic changes like punched-out erosions near the joint, maybe some sclerosis, or even visible TOFI if they're calcified.
Any other imaging?
Ultrasound is increasingly used. It can show things like the double contour sign that's urate crystals coating the cartilage or cloudy aggregations in the fluid. MRI isn't routine but might be used sometimes. And there's dual energy CT, DECT, which is pretty cool because it can specifically identify and map out urate deposits.
So lots of tools, but just to really nail this down, seeing the crystals is the definitive thing.
100%. Finding those needle-shaped, negatively birefringent MSU crystals in joint fluid or aspirating them from a TOFIS is the gold standard. It confirms gout.
And the serum uric acid level?
It's a major risk factor, and a high level supports the diagnosis, but it's not diagnostic on its own, especially during a flare.
Got it. Okay, diagnosis confirmed. Let's talk management. What are the main goals here?
Really, there are 3 main goals. 1, relieve the pain and inflammation during an acute attack, get the patient comfortable quickly. 2, prevent future attacks from happening. And 3, lower the body's overall uric acid levels to stop crystals forming and prevent long-term damage like joint destruction and TOFI.
Makes sense. How do we achieve those goals? Let's start with medications.
Okay, for the acute flares, the mainstays are NSAIDs, non-steroidal anti-inflammatory drugs, colchicine, or corticosteroids like prednisolone. The choice depends on the patient, other medical conditions, potential side effects, etc.
And for long-term prevention.
That's where urate-lowering therapy, or ULT, comes in. The goal here is to lower the serum uric acid level consistently. The first-line drug is usually allopurinol.
Anything specific to know about allopurinol?
Yes, a very important point, especially for exams. In certain populations, specifically people of Han Chinese, Thai, or Korean descent, there's a recommendation to test for a gene called HLA-B58.01 before starting allopurinol.
Why is that?
Because having that gene significantly increases the risk of a very severe skin reaction to allopurinol. So screening is advised. Febuxostat is another option for ULT, and for really resistant cases, there are other agents like canakinumab, an IL-1 inhibitor.
And I remember you mentioned something about starting ULT.
Yes, good point. When you first start a ULT, like allopurinol or febuxostat, it can sometimes actually trigger a gout flare as the urate levels shift. So we usually co-prescribe a prophylactic low dose of either colchicine or an NSAID for the first few months, typically up to 6 months, to prevent this.
Okay, that covers the main drugs. What about lifestyle? How important is that?
Hugely important. Lifestyle modifications are a cornerstone of gout management. This means things like weight management if overweight, regular exercise, and those dietary changes we talked about.
So cutting back on alcohol and pure-enriched foods?
Exactly. Limiting alcohol, especially beer and spirits, and reducing intake of red meat, organ meats, and certain types of seafood. Staying well hydrated is also important.
So it's a combination approach.
Definitely. During those quiet periods between attacks, the focus is really on education, helping the patient understand their condition, identify personal triggers, and reinforcing the importance of weight, exercise, and diet. Then, for acute attacks, it's prompt treatment with NSAIDs, colchicine, or steroids. And long-term, it's about that urate-lowering therapy combined with lifestyle.
You mentioned lowering uric acid levels. Is there a specific target?
Yes. The treat-to-target strategy aims to get the serum urate level consistently below 360 micromoles per liter, which is 6 milligrams per deciliter. Keeping it below that level helps dissolve existing crystals and prevent new ones forming.
And how often do you check levels?
Once someone is stable on ULT, their serum urate level should generally be checked at least once a year to ensure they're staying on target.
And when should we think about referring to a specialist, like a rheumatologist?
Referral is a good idea if the diagnosis is uncertain, if the gout is proving difficult to control despite standard treatment, if there are significant complications like kidney stones or severe TOFI, or if there are tricky medication choices due to other health issues.
Okay, comprehensive management plan. What about the prognosis? What's the long-term outlook for someone diagnosed with gout?
Well, the good news is, with proper, consistent management, taking the ULT as prescribed, making those lifestyle changes, the prognosis is generally very good.
Meaning fewer attacks.
Yeah, the frequency and severity of attacks can be drastically reduced. Many people can achieve long periods completely free of flares.
But what if it's not managed well?
That's the flip side. Untreated or poorly managed gout can definitely lead to problems. Chronic joint damage, those destructive TOFI we keep mentioning, and just generally a lower quality of life due to pain and disability.
Any specific numbers on that?
Well, a first acute attack usually settles in, say, 3 to 10 days. But without preventative treatment, something like 62%, so almost two-thirds of people, might have another attack within a year.
Wow, recurrence is common then.
Very common if urate levels aren't controlled. And those recurrent attacks and chronic inflammation lead to that progressive joint damage. And remember, keeping the serum uric acid level high, above that 360 target, significantly increases the risk of those flares coming back.
Right. So effective management is key not just for symptoms, but for preventing long-term joint problems. Okay, finally, let's touch on complications. What are the main things that can go wrong if gout isn't controlled?
We've touched on some already. TOFI formation is a major one. Those crystal deposits can cause deformity and damage joints. Kidney stones are another biggie.
Because the uric acid crystallizes in the kidneys too.
Exactly, in the urinary tract. Chronic gouty arthritis is essentially ongoing joint inflammation and damage. And interestingly, there's a link between gout and an increased risk of cardiovascular disease and hypertension as well.
You mentioned kidney issues beyond stones.
Yes, something called chronic urate nephropathy. This is where urate crystals deposit more diffusely within the kidney tissue itself, causing chronic inflammation and fibrosis, which can potentially impair kidney function over the long term.
So it can affect kidney function directly.
It can. And the risk of developing uric acid kidney stones specifically goes up quite a bit if the amount of uric acid being excreted in the urine is very high. The notes mention over 780 millimole per day as a benchmark.
Any other potential issues?
Well, severe degenerative arthritis in the affected joints is possible. Secondary infection can sometimes occur, especially if TOFI break through the skin, and just the impact of recurrent painful episodes on someone's life.
Are there any really rare complications?
They're uncommon, but yes, TOFI can sometimes compress nerves, leading to things like carpal tunnel syndrome if it happens in the wrist, or even, very rarely, impinging on the spinal cord.
Okay, so clearly managing gout properly is vital to avoid a whole range of potential downstream problems. Phew, that was a really thorough run-through of gout.
We covered a lot of ground.
Yeah. So just to quickly recap, inflammatory arthritis caused by uric acid crystals. Classic flare is podagra, that red-hot, swollen big toe. Remember the male Doty mnemonic for risk factors?
Male, alcohol, low kidney function, eating purines, diuretics, obesity, genetics.
Got it. Diagnosis hinges on seeing those needle-shaped, negatively birefringent crystals in the joint fluid.
Gold standard.
And management is two-pronged. Treat the acute flares quickly with NSAIDs, colchicine, or steroids, and then long-term urate-lowering therapy like allopurinol plus lifestyle changes, aiming for that urate level below 360.
Treat to target. That's key to prevent those complications like TOFI, kidney stones, and joint damage.
Absolutely. You know, what strikes me is how gout really sits at that intersection of genetics, diet, lifestyle, and even other medical conditions.
It really does. It's a prime example of how complex the interactions can be that lead to a common disease, isn't it? The variability between patients is huge depending on all those factors.
Definitely something to think about, that multifactorial nature. Okay, now, for all of you listening and revising for the MSRA, if you want more in-depth materials, practice questions, really solid resources to lock down your knowledge on gout and everything else.
You should definitely check out passmsra.com.
Absolutely. And for even more great resources, don't forget freemsra.com as well. Loads of helpful stuff there.
Good luck with all your studies.